I have the pleasure of introducing Christine Gallagher. Ms. Gallagher has spent over 20 years working in Washington DC on health, human services, and education policy. Currently, she is a research project director at the Milken Institute School of Public Health, where she manages the Stop Obesity Alliance and coordinates research projects in obesity. Previously, in 2001, Christie became the director of the governor of Missouri's Washington office, where she coordinated all state federal issues, including healthcare, education, and homeland security. And after 4 years serving the state of Missouri, Christie fulfilled a similar role for the state of New Jersey. She also served as a key member in two Washington think tanks, Third Way and the New America Foundation. So without further ado, let's welcome Christine Gallagher.
Thank you and good afternoon, almost good evening. So I know you all have been here for a really long time, so we'll go through this and then hopefully have some time over dinner, it sounds like, for questions. So I have a few disclosures to make. The Stop Obesity Alliance, which was mentioned, I'm the associate director of now, we take funding from Amgen, Boehringer Ingelheim, Curex, Eli Lilly, Novo Nordisk, and Pfizer. I also do work for the Obesity Care Advocacy Network, who also receives similar funding. So the objectives of the talk this afternoon is to talk about the disease of obesity, and I never really know who I'm going to follow. So some physicians who are obesity medicine specialists cover everything. So I'll kind of speed through some of those slides, but we'll also talk about the barriers to obesity care. What are the elements of a comprehensive obesity benefit, and what does obesity coverage look like right now? So as was mentioned before, oh look, I was supposed to add obesity prevalence and number of comorbidities there. Oh, well, I'll fix that slide later. As was mentioned before, the current obesity rate is 40.3%. Just a little side note, you might have seen some press around that over the last couple of weeks saying that the obesity rate is going down and it must be from these new GLP-1s. That's not actually true. It's maybe plateauing. We're not really sure the significant and this sort of plateau, or maybe even a tiny bit of a drop. We don't know what that's from, but it's definitely not from the GLP-1s. We're not seeing that. And especially because we're seeing an increase in severe obesity. So from that new CDC data, it's important to note that as you read some of the press around that. The AMA declared obesity a disease in 2013. That's about the same time that I started at GW. I've been working there on this topic for 13 years now, and or almost 13 years. And it's fascinating how things have changed over just the last 2 to 3 years. Definitely since 2019, when the first Saxenda medications already came on the market, the first GLP-1. So we already went over some of the comorbidities. Just a little bit about the sort of tug of war about weight loss, and you talked about that a little bit. But it's important to know that this sort of is constantly going on. And the first time that a patient sort of walks in and talks to their doctor about weight loss or obesity or the significant weight gain that they've had, this isn't the first time that they're dealing with this. It really takes a lot of bravery for a patient to actually bring this topic up with their patient. And as was shown before, if a provider actually brings this up with their patient and they come up with a plan, that's much more likely to see that patient to lose the weight. That's sort of what we're seeing now. The other thing is that we're not seeing coding of obesity. And if you may have seen some news recently, as of October 1st, we have brand new codes for obesity that sort of follow the stage 1, stage 2, and stage 3 of obesity. It's looking at BMI, but also looking a little bit at that Edmonton obesity specialist, or Edmonton staging of obesity. So another reason why this is so important, as you can imagine, is the impact of obesity and people living with the disease of obesity on the economy. So not only is there an impact on the employees and the people living with overweight and obesity, but you're also seeing an impact on employers. And over the last year, this company, Global Data, has done a lot of research to look at what the impact is, not only on the economy in the United States, but it's dug into each state. And on their website there, which is listed, you can go and see the impact of obesity on the economy in each of our states. So as we talked about before, the clinical guidelines of obesity, sort of talk about where you're going to see the significant weight loss, and as was stated before, even a weight loss of up to 5% can have an impact on a person's health. But we see that lifestyle modification, then lifestyle modification plus anti-obesity medications, and then the weight loss that you can see from the gastric band, the gastric sleeve, and the bypass. So we also know that there are many medications that are in the pipeline right now, and we're seeing they are going to exceed the level of weight loss that we're already seeing and that we've seen for surgery. So better treatments are on the horizon, and this field is just going to become much more competitive, both competitive for the pharmaceutical companies, but also just in general, we're going to see a lot more help out there for people on the horizon. However, right now we have a lot of barriers to the access to obesity care. So obesity care is often excluded from coverage. It is piecemeal when it is available, and it's dependent on a person's employer. It's often and also dependent on their insurance plan, their zip code. And then when there is insurance, there are often hurdles that patients must meet in order to be able to get that approval. The prior approval process can be maddening. And then even if they can get the treatment, they get the prescription, they get the approval, then it can often be unaffordable. So over the last decade, the Stop Obesity Alliance has been looking at what research, we've been looking at what coverage for obesity treatments are available. And as we did that, we began to realize that it's not consistent across the board. And it was very frustrating to have to go through all these plan documents to try and figure out what is available. We had to search for words from everything from diet to obesity to obese to weight. And we realized that there really was no sort of comprehensive obesity care benefit. So we decided to develop our own. So I'm going to go through the elements of the Stop Obesity Alliance's comprehensive obesity benefit now. Just also to point out that it follows evidence-based recommendations from all the medical guidelines, as well as it supports a clinically significant weight loss of at least 5%. So, starting with patients with who walk into any doctor's office, they should be screened for the provider. They should be screened annually for obesity, and if they are diagnosed with obesity, which means technically a BMI of greater than or equal to 30, or 25 to 29 with a risk factor or a comorbidity, then they should be offered or referred to an intensive lifestyle intervention. Many primary care physicians don't have the capacity to do that intensive lifestyle intervention, so they should be referred out, and then they should be screened for any complications. And then when a patient does get the intensive behavioral therapy, it should include a cognitive behavior change component, as well as physical activity and nutrition counseling. All plans should also offer all FDA-approved medications for the treatment of chronic weight management. I actually put the brand names in here. You went through the actual generic or technical names. But those are all the medications that are on the market now, as well as, and you touched on this as well, the weight-centric prescribing. So it's important that when people are living with the disease of obesity, that they are not also prescribed other medications for other conditions that will have a weight gain. And so health plans should offer that as an option for people. Metabolic and bariatric surgical procedures should also be covered. It's important that health plans also cover revisional procedures. So, and when there are complications with surgery or when inadequate weight loss is achieved, despite the adherence to treatment, they should be able to have at least one procedure to correct. So at the Stop Obesity Alliance, we've been looking at this for since 2009, and this past year we were able to get access to a new database from a company called Leverage, and we looked at not only what is coverage in state Medicaid plans, but what are also the restrictions and limitations. So it's a little bit difficult to see and for me to sort of put in a slide because it is it's such a great resource to see this when you're on our website, but you can sort of click on each state. You can see what their population is, what the obesity rate is, what the adult diabetes rate is, and then you can see what how many patients or how many people in the state have coverage through Medicaid. And then we went through and stated sort of what was covered and not covered. So in this instance, we have nutrition therapy is not covered, intensive behavioral therapy is covered with limitations. This is for the state of Florida, and medication's not covered. And it looks like the bariatric surgery piece got cut off there, but it's a really great resource. We also have state fact sheets for each state. So if you wanted to look and see, say, for example, the state of Maryland, you would be able to see all of that, as well as what the limitations and restrictions are that we were able to use or look at this year. And so this slide actually kind of goes into some of those results. So for the state Medicaid plans, 23 states do cover nutrition counseling. 16 states provide that intensive behavioral therapy that we've talked about, but 34 of them cover that with limitations. And then 14 states cover obesity medications. Then there's another 5 that actually only, they might say that they cover medications, but they're only covering the over-the-counter weight loss medication, Orlistat. So in our research, we said that that was not coverage. And then all but 2 states do cover metabolic and bariatric surgery, which is great, except for 28 of those cover surgery with limitations and restrictions. And we have a poster and presentation that'll be coming up next week at Obesity Week, where we're going to go into the details of what these limitations and restrictions are, but you can also find them on our website under this research. So another great resource, and this is free as well, is using the same database that we had access to, but it's published in connection with the Robert Wood Johnson Foundation. And so this slide shows that, that what coverage looks like for state employee health plans. So what's really great about this one is you can actually hover over to the left when you're in the web, on the website, and you can click on what type of coverage you want to look at. So if you want to look at employer coverage, if you want to look at like whether there's Medicare coverage, if you want to look at what federal employee coverage looks like, all of that. But you can only look at it for medication and surgery. And the other thing is you won't be able to look at some of those limitations and restrictions that we had access to. I also just I put in a new slide here to my presentation because this research that came out recently. It's from the Kaiser Family Foundation, and they have an annual employer health benefits survey. And just to show you that about 18% of the employers that they surveyed are currently covering GLP-1s for weight loss. And of those, 53% have some type of condition or requirement associated with covering these medications. So in our research, we would maybe call that a limitation or a restriction. Others call that something else, but it's sort of a type of condition that must be met. And then of those that are not covering, and this was interesting, 62% said that they are not likely to begin covering within the next 12 months. 23% said that they are somewhat likely to do so, and 3% said that they are very likely to do so, with 11% not sure. So just my concluding thoughts, obesity is a disease, it's not a lifestyle choice, and that's sort of number one. Number two behind that is, it comes along with it, but there's a lot of stigma and bias that people living with the disease of obesity feel, and, we really need to address that. Obesity dramatically reduces the economic activity and costs the economy, and the solution is the comprehensive obesity benefit. It's really a model for what coverage look like. There's only one place that we have found that uses it right now, and that's the Federal Employee Health Benefit Plans. The OPM came out, over the last couple of years saying that all health plans that are underneath the Federal Employee Health Plans need to provide this full comprehensive benefit to their employees. So here's some of the resources that I've mentioned. We have the elements of the comprehensive obesity benefit. I also have that checklist, which is there. This is a great way to sort of pull that up, go through your own health plan, see what is offered to your employees or what is offered to you as an employee, and then to be able to advocate for better coverage. And then our Medicaid obesity treatment coverage that I talked about, as well as that resource for the leverage obesity coverage nexus, where you can sort of look at all the different coverage that is out there. And then that's my information. Can we take a few questions?
Yeah, probably could. I didn't realize we'd have time.
I went fast.
Yeah.
Yeah, go ahead.
Just want me, come on down and.
Yeah, I didn't track my news flash, but, I was, and all these drugs are coming out recently, well, Walmart said they're concerned because people aren't buying snacks. And they are adjusting their budget, you know, I was like, wow. So is that a plateau, like you said, you know, is that this?
It's interesting. I mean, you know, I've seen the same sort of media and press on that, and as well as sort of the economic impact, or at least in like the stock market, of what people are saying. I think what we might see in the future is that the way that people eat is gonna change. I think, you know, there are some companies, I think it was Nestle, that came out and said that they were gonna offer sort of these packaged meals for people that are on, you know, GLP-1s and so forth. You're also just gonna see so much in the media right now about, I mean, if you watch any type of TV, you're gonna see a commercial. If you're listening to the radio, you're gonna hear a commercial. There's so many different plans, programs that are out there right now. A lot of them are offering compounded medicines, which we advise against. It's much better to go to a weight loss clinic, see a doctor who is trained in obesity medicine or bariatric surgery to help you with this, and that's what we recommend. But really, there's just so much out there, and like the words GLP-1, there was an article in the Atlantic just a couple weeks ago about sort of companies using those words, GLP-1, and then taking them and talking about something that's totally not related at all to that medication. So I don't know what the impact's gonna be on snacks, but I do know, I'm a person living with the disease of obesity. I've been on medication since 2019. Definitely changed the way that I eat, but it also, I don't deny myself of things, but I, you know, try and get more protein in, definitely am like buying more like protein bars, protein drinks, that kind of thing, to make sure that I'm getting the food that I need, because I'm just not as hungry. So, is there a question?
Yeah,
King's gonna ask a question, then I'll come down to you, Carl.
from a Ahmed perspective, I'm really curious about the future of sleep apnea management, given that tirzepatide has been shown to improve sleep apnea outcomes. So I wonder what your thoughts are on the future of sleep apnea management. Is this gonna be like in conjunction with CPAP use? Just wanna see what I'm gonna see in clinic.
The recommendation is when people lose that 7 to 10%, that we see that significantly has a benefit for people who have sleep apnea, that we retest, right? So after having an intervention like bariatric surgery, where somebody is likely to have a much higher percent weight loss than that in 6 months or at whatever point, it is recommended that they have another sleep study. That said, it does depend a little bit on a couple of factors, right? Some people are at risk for sleep apnea regardless of BMI. Sometimes their airway is just gonna be small and they're gonna need some support. So there are plenty of people, or that percent reduction doesn't then bring them out of a risk category for having sleep apnea. So it depends on the person. Retesting is probably gonna be very important and become more and more important as more people achieve these greater percentages of weight loss. At the same time, I have many patients who retest and they still need a CPAP. So I don't think CPAPs are going anywhere anytime soon. But it is important to keep monitoring and to have that structure.
Most people who know me know that I've lost a fair amount of weight over the past year. But it raises two issues. One, I would add to your barriers the actual availability of the medication. I'm having an awfully devil of a time. I'm diabetic and I'm not ashamed to admit it. I'm off insulin, by the way, with weight loss. But the availability of Mounjaro particularly has been horrendous. I mean, I've had to adopt a lifestyle of stretching out between times because I can't get it. But I'm not unique. Others cannot, and it's not unique to the one medication. The second one is more of a question. I've seen in the literature discussion about whether BMI is the best way to do it. It's an easy way, but is it the best way? But if you're going to use BMI, do you use the original height or do you use the usual shrinkage height?
Well, you can probably answer more of the technical question, but I will say that we are doing some research at the Stop Obesity Alliance to look at measures and also sort of what should go into the diagnosis of obesity, that it shouldn't just be BMI alone. There's several different things that are happening right now. The Lancet Commission has a report that's supposed to come out. Last rumor I had was early winter, but they're going to be looking at sort of what is the definition of obesity and then what should the diagnosis of obesity be. I'll talk a little bit about these new ICD-10 codes. So the codes for obesity, we weren't able to remove some of the codes that are very stigmatizing, such as obesity due to excess calories or morbid obesity. Those are still going to be on there, but what we were able to do is to add new codes that then should be used with the Z codes to sort of look at what the BMI is. And our instructions are that even when the person begins to lose the weight and their stage changes through that, they should still be diagnosed. But ICD-10 code should still be the original code like they do for diabetes, because it's important that the person be able to continue to get their coverage, right? That's really important.
So they don't stop.
Right, exactly.
Always.
They're always going to have that diagnosis of obesity. So I don't know about the shrinkage part.
Yeah, so BMI is a very limited indicator of health status. I think everybody agrees that we've been trying to replace it, and there's a lot of advocacy for that. It's very hard to replace because it's so easy to do. And so already we're having so much trouble just getting a BMI when people go even to a primary care visit. Often those codes aren't there and it's a big problem. So I don't think it's going to be replaced anytime very soon, because someone would have to look at comorbidities or the body roundness index, which there have been a lot of articles around that recently, like is somebody elliptical shaped or rounder? There's a lot of interesting mathematical things that actually are better indicators of health. That said, I think that the height, if we're using a BMI, should be the height that you are currently, because again, the population data is looking at someone's current height versus their current weight. And then supply, you're right, is a huge problem, and that's a huge access issue where there's lots of lapses in therapy. Often we're using other medication classes to try and still support the metabolism and kind of that endocrine system in some way in between, but it's a big problem. We're hoping that in the next couple of years, it won't be as much of a problem because the pipeline is so promising, right? There's a lot of different options that are going to be available at some point, and that should help with access the more options there are.
Thank you. Carl, I just wanted to say congratulations. If you're wondering where all that weight went,
I've been thinking about, the motivation of employers to cover this, and of course, employers, they see the short-term extremely high costs of these medicines, and they may not see the benefits of the real, the savings from the chronic diseases down the road. But it seems like the federal government, I think, is different. You know, if you're a federal employee, you tend to be a federal employee forever, and I'm wondering if that's why they were the first to kind of jump on. And whether we might, you know, like what your thoughts are about whether Medicare is going to start covering it, and whether that will kind of open the gates for other employers to follow suit.
Yeah, those are two really very good questions. So we began working with OPM, like 4 or 5 years ago on this, and I think there were a couple of reasons, but one of them definitely is the fact that when you're a federal employee, you tend to not only do you tend to stay a federal employee, but oftentimes your children become federal employees. So there is a lot of sort of consistency there, and then being able to see the return on investment. I hate using that term though, because here's the thing, we don't look at return on investment of a cancer patient. We don't say, well, this person, you know, we should look at what's the return on investment if we give them, you know, all of the medications and treatments that they should be able to get and access. And so we treat people with obesity in a different way, and that's just, you know, one sort of like caveat I just wanted to put out there. As far as Medicare, so we've been working on the Treat and Reduce Obesity Act for over 10 years now. This is the year we've gotten the closest to doing that. So for those of you who aren't familiar, Medicare Part D excludes medications for both weight loss and weight gain. That was part of the original law when it was passed in the early 2000s, or sorry, early, yeah, 2000s. And so one of the things that we need to do is to either change the law or have CMS and FDA sort of really look at these medications as not weight loss medications, but as obesity management or the disease or the treatment of the disease of obesity. So yes, this is the time that we've gotten the closest to getting it passed. It has at least passed out of one House committee. We're in conversations with the Senate to see if we can maybe possibly get it into a sort of big, large health care package when they come back after the election. It really depends on what happens in 10 days, what we're gonna sort of see as far as that goes. But even if we do get something, it's probably gonna be sort of a minimal sort of fix. We'll still need to work on sort of what happens there. Also, just wanna point out, there's another part of that bill called, it's the Part B side. So right now Medicare covers intensive behavioral therapy, but only if it's done either by a primary care physician or done in a primary care setting. And so that excludes a lot of registered dietitians, nutritionists, it includes obesity medicine specialists. It's crazy, like it excludes endocrinologists. So we're trying to get that fixed as well, either through the legislation or we are trying to submit a new coverage decision memo to CMS to see if we can get that fixed.
Christy, I had a question, because you brought up Medicare. I read in my favorite medical journal, New York Times, that the National Health Service was paying so many millions of dollars to Eli Lilly for their medication. And I'm wondering if that's something that the US would consider doing as well.
So yeah, so that's sort of new policy that just came out of England, and yeah, I don't know, that hasn't sort of been talked about at all as far as like a possibility. The closest I would say you could get to that is whether we could do some type of CMMI type research and see what it looks like. I think, you know, what members of Congress are really looking for is that, what is the return on investment? You know, if we spend this much on these medications now, are we gonna see sort of healthcare costs go down, you know, in the future? And really what you wanna see is coverage for people in their, you know, 40s, 50s before they even get to Medicare, because that's gonna decrease the costs of the healthcare on, and the pressure on Medicare in the future. But oftentimes, you know, employers do follow what Medicare does, and so we're really focusing on sort of the Medicare change as well. Also, state employee health plans, so people who work for their states also tend to stay in, you know, teachers, firefighters, those who are covered sort of under that state employee health plan, and also their retirement benefits. And so they, so there hopefully maybe a way that we can sort of get that change done as well.
So just out of curiosity, like for your obesity medicine clinic, is that more of a continuity clinic, or you do like consultation and then transfer to primary care? And is there any data showing greater success when they follow up with specialists versus if primary care is taking over their long-term management?
That's a
Because I know for primary care doctors, like, the problem is always time.
Yeah.
You don't have time to do all the things that you can coach for instance.
Yes, that's a great question. And yes, it's a continuity clinic, which makes it hard for access, right? Because I know for our clinic, the wait list is over 1,000 people because we see people go on an ongoing basis, right? At the same time, the kind of benefit, the health benefits are much greater when they come to see us because it fits those criteria that we were talking about earlier for an intensive lifestyle change, right? We're able to counsel them. We have a little bit more time than many primary cares. Our visits are 20 minutes instead of like 15 or 10 minutes. They don't overbook us in the same way. So I don't think it's been studied looking specifically at a obesity medicine physician versus somebody who's in primary care, but the model that we get to use has been studied and the outcomes are different for that. So most of the obesity practices that I know of tend to do that continuity care. They're doing the monitoring, they're doing the structure. A lot of them will do some outsourcing. So they'll be like a dietitian as part of their team, a psychologist, an exercise physiologist. It's a whole comprehensive model and people tend to do well. And we talked about it, that obesity is a chronic, relapsing, progressive disease. So what we've seen is if we graduate people when they achieve their goal, it tends to be kind of short term, especially if they're not on something like an anti-obesity medicine, right? Or they haven't had another intervention. So that's why we have our model the way it is. We space out clinic visits as people, you know, go into weight maintenance or are better supported and have the tools that they need. At the same time, we see that when we space out visits, people start to have a little bit more relapse as well.
So just so everybody knows, I got my 10,000 steps.
So my question is simple. I just didn't see much in the way of, mentioning about stuff like 12-step programs and 12-step facilitated programs, Overeaters Anonymous. And the other thing was I didn't see much mention of drugs like Vyvanse or lisdexamfetamine, which is indicated, I think one of its only indications for binge eating disorder, which I also didn't see mentioned. These are taboo topics for the very obvious reason that we don't like to always admit that mental illness is illness. Just curious what aspect and what role you guys think that psychological wellness plays in this. And I would imagine, at least in my experience as a physician, the people that I see actually get better usually will tell you that the mental was the number one most important thing by far. So just curious your guys' perspective.
So I'll say for our clinic specifically, we screen everybody for binge eating and night eating syndrome because there's such a significant impact on long-term weight loss success and health goals if people meet the criteria for those things. And we work with certain psychologists who that's their specialty area. So it's very easy for us to refer for people to get seen. They see those healthcare providers, those mental health care providers very regularly, right? So we're really lucky. That said, is that true everywhere? No, right? Like a lot of people, obesity medicine is quite variable, which is one of the big problems right now, right? There are people who are practicing it who don't necessarily have the same, goals for their patients. There's some very drug-focused providers out there. Not everybody's doing the whole mental health assessment with it. there's a lot of data, you're 100% right, that it's very important, right? We talk about the pillars of long-term health being stress management and mental health, as well as sleep and nutrition and exercise, right? So all of those things, we're lucky enough to have the time to talk to our patients about. Our initial visits are an hour, which is really wonderful and luxurious. At the same time, you're right that many obesity medicine providers don't use things like Vyvanse. We use it a lot because we're able to diagnose people with binge eating disorder.
Because you asked.
Yes, because we ask, right? And people are looking for that support and they want to talk about these things. That said, because the indication is specifically for binge eating disorder, right? A lot of people don't get screened, a lot of people don't get access to that care, and Vyvanse also has a problem with supply, right? So, yeah, so when people do actually get put on it, then the same things that happen with the GLP-1s happen where they go on and off with access, and that can be really tough, especially when we're treating something where they don't necessarily have psychological care as well for it. We luckily do, but not everybody does.
I have a question. So I'm not prescribing these medications, but my understanding is that Ozempic in particular will metabolize not only fat, but also muscle. And particularly with individuals that are aging, they're having sarcopenia anyways. How do you help your patients to recover that muscle mass, which is so crucial, particularly as you advance in age?
100% right, and I can let you also talk to this a little bit more, but it's really important that you do the things that help prevent muscle mass that are evidence-based, right? So having a strength training, kind of resistance training part to the plan, again, the structure is so important. We often think about these drugs in isolation, but really it's going to become more and more evident, I think, since so many people are using them in maybe not the best way without a structured plan, that there's a huge difference between people who have support who are using medications versus don't have support, don't have a structured plan. So if we build in resistance training early on, if people meet their protein goals, protein is very protective against sarcopenia. And not everybody has the same targets. We talked about how that 3 to 5% for some people is the right target. We tend to use lower dose and go a lot more slowly in patients who are over 65 in our clinic, right? We don't have the same goals for everybody. So it's important to factor all of that in, and that's why we really believe that it's important to have like a comprehensive care provider who's part of the team, who's talking to patients and kind of making a plan with them.
Well, I would just say that I think the research is still completely out on that as well. Like, I think that is something that has been reported, but on very sort of small studies. And, you know, these medications are so new, they're so powerful. We're still, you know, getting the data in. And so there is some sort of, I've read some research recently that it's not always sort of muscle mass, it's a different type of muscle, you know. And then the other thing I was just gonna point out is there are medications in the pipeline that will address both things. So it's targeting sort of the fat and not the lean muscle, and so forth. But as far as like what we talk about with getting like the Treat and Reduce Obesity Act passed, and because that focuses on people over 65, is there's gonna be a point, there's gonna be an age point where these medications really aren't, they're not indicative, they're not helpful, they're not, you know, there'll be a point where the patient really shouldn't be on them anymore because of those reasons, so. Yeah,
I'm just gonna,
you have the mic.
yeah, I know, I see the mic. I am Paul Dempsey, I'm with Novo Nordisk, we manufacture Ozempic and Wegovy and have really led a lot of the research in the GLP-1s. We're a diabetes company, we were shifting to a metabolic health company, really to, in a way, put ourselves out of the diabetes business. And I think it's really important to know that a lot of great questions. I think the work that our two speakers do really helps us to start to look at accepting obesity as a disease and actually working towards solving it. The challenges we face with our insurance coverages in the country are big. I've been on an employer team at Novo for 8 years, just focused on obesity benefits. We've done a lot of state work with states and the federal government, and really trying to identify the right risk and then the right care. So when it gets to ACOM and the work we do there, we've been involved with ACOM for a very long time. Right now, we're trying to do a research project with them on patient-reported outcomes because it gets back to functionality and the ability to work. And, it's really important that as the work you guys lead, one, like Christy said, making sure the benefits are available. And if you can have any resources like the work that Dr. Bosch does available to the workers is huge. Because the way everything works today is really gamed against the patient to not get to health. I can just tell you that the benefits are horrific. Even the pharmacy, you know, you get into the pricing thing, I do a lot with the finances. Prices aren't real. Everyone believes they're real. But the money flow is all kind of hidden. And that's a very frustrating thing. Especially when you hear what you hear on a day-to-day basis, that the patients are holding the brunt of that. Because, you know, on the medical side, they get access to net costs, but they don't on pharmacy side. And, you know, it gets kind of perverse. So that's where anything you can do to help patients understand this is a disease and to get healthier and return to work at a better opportunity. It really overall patient health, and the discussion from today that you outlined, Jeff, I think is key. Is we need total worker health, patient health, because it really will change the game in the future, but we have to embrace this as a disease. So I'll leave it with that, and I'm looking forward to the next step.
And I'm just gonna, have one more question from Iris.
While we wait for Iris, I'll just point out one other great resource is the Obesity Action Coalition. So they are the only patient focused organization in the United States, and they have so many wonderful resources on there, especially on stigma and bias. And they also just released a new sort of photo database that has, you know, real people living with the disease of obesity, their photos. It's a free photo bank. Because when you think about it, think about the last news report that you read or website that you went to and you saw it was a story about obesity. It either was someone shown from their backside or it was someone shown from their neck down. We call those butts and guts pictures. We're trying to get away from that. You know, people are real people. They're people living with the disease, and they're not, you know, they're not who the disease isn't who they are. So sorry.
Well, one thing that's not a question is tomorrow I'll be speaking about sleep apnea and the World Trade Center responders. And I don't know if you're hanging around, but we have this discussion often. But my real question to you is, what percentage of people in the United States that are receiving these medications are going to clinics like yours? Because I see a lot of people that are getting random prescriptions for Ozempic or Mounjaro, and then it runs out, and then they get it from Mexico or wherever they're getting it from, and then they come and they ask our advice about it. So I think it was an access to care issue because it's kind of not the greatest medicine to be giving those medications without doing some of the other things you do. So if you have any idea of that statistic, I'd like to hear that.
I don't, yeah.
It's really hard to tell right now, and I think it's a very small number, so that's one of the big problems. So the access is not great, and then even when there are clinics, the provider kind of approach is so variable. So this is a big problem. I think there's a lot of companies that are trying to come up with different care models to approach this differently. There's a ton of telemedicine companies I know that are in this space to try to just make things accessible where there will be a dietitian on board, not a mental health provider. So that is one downside. So there's, I think, a lot of that needs to evolve in this space, a lot of opportunity that we haven't met yet. At the same time, I think that there's a lot of people thinking about this, so I'm hoping that it will get better. And many people are training, so it's still a relatively new field. So more and more people are, going through certification or going through fellowships. The number of fellowships are growing. More and more people are interested in this space. And when people know how to prescribe safely, it's going to be a much better outcome for patients. So there'll be more providers who are obesity medicine trained, which I think is important.
I was gonna say during my bariatric rotation, this would have been in 2016 or 2017. The statistic thrown around by the bariatrician was 68% of people who met criteria for referral to a bariatric surgeon were not. So, I mean, from what we do, when we see these folks on pre-employment screening, I mean, to me, that represents an opportunity to stop somebody and say, hey, look, this is getting in the way.
So, thanks very much for the presentation.